for you the new technique that I developed. It's a sandwich technique. Okay. So what is the case for chimney graft? It's facilitating bar of justarenal and suprarenal aneurysm in urgent setting or high-risk patient. That's because this branch graft from Cook, it takes some time to get ready to use your patient. So in a patient with back pain, patient with a rupture, thoracoabdominal aneurysm or justarenal aneurysm, it's going to be almost impossible to treat with the branch graft. So that's one example that I think is a very good thing that you can do with the justarenal. So this patient is a very short neck, less than 5 millimeters. So I deploy that screw the luminal graft very close from the renal artery, as you can see here. And in the angiogram, the completion is a huge type 1 endoleak. At the same moment I took the left brachial approach and the right brachial approach, the left brake for the left renal. As you can see, I put the long introducer. It's a Cook long introducer, it's a hobby. It's a 70 centimeters long. It's an H French. And use always a self-expandable cover stent. It's like not so viable. So as you can see, I deploy. It's not so far from the renal artery. After that, with a balloon, the proximal, I deploy the proximal cuff. This was a 32 millimeters diameter excluder cuff. It's a 4 centimeters long. And always now, I deploy, as you can see here, that's I stent, a barrier stent to avoid kinking and occlusion of the cover stent of the renal. I already have 3 patients with occlusion of the renal in the patient with the hemodialysis. So now I always deploy a barrier stent in the fluency. Okay. That's the final angiogram. So you can see no leak at all. And I did this patient 1 month ago. And that's the CAT scan. And this procedure, all procedure took like 2.5 or 3 hours, almost 3 hours, skin to skin. So it's a real, very, very easy procedure. So let's talk about for thoracoabdominal aneurysm. This one's a type 4, as you can see here. It's from the SMA. And this patient has no left renal, just almost occlusion in the left side. And a huge 11 millimeters aneurysm. So that's the angiogram. I have no proximal neck, so I needed to cover the celiac axis because I need for chimney graft at least 3 centimeters of the normal aorta. So SMA was involved, as you can see in the CAT scan before. So I always shoot an angiogram from the SMA. If I can see the celiac axis open, I can occlude without any preoccupation. So that's a deploy of fluids for the renal and the SMA, as you can see here, and no leak at all. Now I have a 1-year follow-up of this patient. This patient still open the right renal and the SMA, and you can see the CAT scan here. Still 11 centimeters aneurysm, a huge aneurysm, but without endoleak or pain. So this patient is treated for 1 year, 12 months follow-up. Now, well, let's show now for type 4 thoracoabdominal aneurysm. So you can see the celiac axis, the SMA, but as you can see here, it's just a type 5 aneurysm just when beginning of the right renal artery. It's a huge aneurysm with the patient with severe back pain. So I did, as you can see here, I came always from the arm, left and right arms. So I put the wide, that's now I begin with the Terumo wide, it's a 260/035. Then I exchange now for a J3 for Jotec, it's a very short tip. And then I deploy first the cover stent and then I deploy the endoluminal graft. After that, I balloon and shoot the angiogram, as you can see here. In this one, it's a 1 month follow-up. As you can see, both renal open SMA. And this one's a 10 months follow-up of these CAT scans. You can see very clearly the 3 fluencies open and without any endoleak in this patient, almost 10 months now. Well, but the tube graft is not appropriate for type 1 to 3 thoracoabdominal aneurysm because you don't have the length enough from the fluency, and as far you go to the fluency, the probability of the occlusion of this fluency is high. So I think for Chamine you have to restrict to type 4, type 5, or just a renal. That's why I developed one technique to treat this kind of aneurysm, or it means type 1, 2, or 3. So this patient is a 70 years old male with a huge type B dissection and huge aneurysm, almost 10 centimeters long, up to the renal arteries, as you can see here. So it's impossible to treat this patient with Chamine graft. So that's the new technique that I developed. I start deploying 2 endoluminal graft because it's too far from the left subclavian up to the celiac axis. So you need almost 200 centimeters endoluminal graft, 200 millimeters endoluminal graft. I stopped just above the celiac axis. Then I come from the brachial artery and select both renals and SMA. After that, I deploy a fluency, 3 fluencies, and then finally I deploy the endoluminal graft. The third endoluminal graft can be a tube for type 1 or a bifurcated endoluminal graft for type 2 or type 3. So let me show this case that I did. That's the final results. So you can see the angiogram. All visceral arteries are open. And that's the 1 month follow-up. And that's the CAT scan. That's a 1 month follow-up too. So you can see here the huge thoracic aneurysm and completely excluded. That's the first stent graft. That's the aneurysm completely excluded. Come to abdomen. And so you're going to see now the 3 covered stents between the 2 endoluminal grafts. Why? That's why here. That's why I say it's a sandwich technique. So endoleak, no endoleak at all. And you can do that. Just I have a patient now. I can do that after now or tomorrow. Doesn't care because you have all this material in your hospital. It's not a problem to do this procedure. And this one's a 6 month follow-up. How it looks. It's a very simple technique. But with sandwich technique, I can treat not only thoracoabdominal aneurysm, but I can treat the hypogastric or aortic aneurysm, as you can see here, in that 8 steps. So first I deploy the modular main body of the endoluminal graft. After that, I come from the left brachial and I catheterize the left or the right, it doesn't care, the hypogastric artery. And from the femoral, I put a wire. And then I put from the brachial artery the viaband or the fluency, a cover stent. Deploy the fluency to cover stent, and then I deploy the contralateral limb in the ipsilateral limb. But it's very important here, must be 1 centimeter below from the viaband of fluency, but the overlapping between the fluency and, or viaband and the iliac limb must be at least 6 centimeters long. So if you have a bilateral aneurysm, so you can do the same way that I already told for you. So that's some sample that I did. That's a bilateral iliac aneurysm without proximal neck. That's almost 4 centimeters. That's the first angiogram that you can see here.